Hey everybody, this is the last part of our chapter 16 lecture on the endocrine system. So we're going to start with how hormones interact. We've already talked about all the different glands of the endocrine system and what hormones they produce and the impacts of those hormones. And now we need to sort of dig into some of the details, and then we'll get into some of the clinical correlations that might be of interest. So, first and foremost, let's take note of the fact that your extracellular fluids, those are the fluids that just surround your cells, that they contain a mixture of hormones, and that mixture of hormones can change daily to weekly to monthly to support homeostasis based on meeting the needs of your bodily functions. Each cell in your body can have multiple receptors for different hormones, and they can have receptors for different hormones. And so all cells are not exhibiting the exact same receptors. They're going to have different combinations of receptors that will respond to particular sets of hormones based on the functions and needs of those cells. And that means that they can get multiple messages at the same time, and that across body tissues, different messages can be coming in. So there are four ways that hormones can interact when a cell is displaying receptors for multiple hormones. There are going to be different ways that if those different hormones are binding to receptors at the same time, there are four ways that we can see those hormones interacting. So the first one is an antagonistic effect. So this is where one sort of negatively or shuts down the impact of the other. So one example would be insulin and glucagon, right? Because insulin is going to decrease blood sugar levels while glucagon will increase blood sugar levels. Another type of effect is the additive effect. This is when two hormones results in an effect that is greater than the effect that either hormone alone would have. So it sounds exactly like the name. It's additive. Permissive effects are when one hormone is actually needed in order for the other hormone to have an effect. So basically you need hormone number one to bind to a receptor in order for hormone two to either bind to the receptor or for when it binds to have any impact on cellular activity. And then the last type is the integrative effect, right? These are when if two hormones are binding to receptors on the same cell, that they will have different impacts, but those impacts will be complementary on that cell or tissue. So they might help coordinate physiological activities in order to get the best result. So one example of that might be calcitriol and parathyroid hormone, for example. So just, it's important to just remember that everything we learn about, we kind of look at like more simplistic models, but there's always a more nuanced sort of complex mechanism or strategy underlying those models that we use, that we try to simplify it in order to make it easier to understand. Okay, so real quickly, let's talk about each of those individually. Here's that antagonistic effect. Some examples would include PTH and calcitonin. So basically, based on how much of either one of them is binding to receptors is going to send the cellular activity in one direction or the other, but those effects will be opposite one another. Those additive effects, another word for that is synergistic. So again, they are going to result in a greater impact than either would alone. And the example they give is the effect of growth hormone when it's binding in the presence of glucocorticoids, which remember are anti-inflammatories. Those permissive effects, you need one hormone in order for the second one to have an effect. Epinephrine is a great example of that because it requires the presence of thyroid hormone for it to have its effect. And then those integrative effects, we're going to get complementary impacts as a result of these two hormones binding. And this is going to be important for the coordination of physiological systems. And again, a great example of this is going to be calcitriol and PTH on calcium metabolism. Okay, so that's the different ways that hormones might interact when multiple hormones are binding to the same cell. So let's look at a bit of an example, which would be how we regulate blood pressure and volume. So notice right away that that's going to require quite a number of endocrine structures. We're going to need the pituitary involved, we're going to need the adrenal glands involved, and we're going to have some secondary endocrine structures in the heart and kidney. So endocrine cells that reside in the heart and kidney will also be needed. So in the heart wall, there are specialized endocrine cells that respond to stretch. And when they are stretched, that causes natriuretic peptides to be released by those cells. And when that natriuretic peptide is released into the bloodstream, it has a number of downstream effects. So we're going to see sodium and water will not be retained. Our thirst will be suppressed. So we won't be thirsty and we're going to pee a lot. We're also going to have the effect of inhibiting renin, ADH, and aldosterone. And all of those typically help us retain fluids. So in other words, if blood volume is large, that leads to increases in blood pressure. And one way to lower that is to release fluids from the body. So the kidneys can help us get rid of sodium, and then with sodium will go water. And if we don't drink more water, our blood volume should decrease over time and reduce blood pressure. We're also going to see the opposite effect, that when blood flow to the kidneys gets too low, so in other words, blood pressure and volume are down, so the opposite of the situation we just described, we're going to see a different release of chemical messengers. We're going to see erythropoietin and renin released into the bloodstream. And when that happens, that's going to activate that renin angiotensin aldosterone system, which is sometimes called RAS for short. And the major consequence of activating the RAS system is we are going to increase fluid intake. So we're going to feel thirstier and we're going to hold on to sodium. And when we hold on to sodium, we will also hold on to water. So that would help us to bring up our blood pressure and volume. And if we look at that in a diagram, we can see that here. So if our blood pressure gets too high, so that's the disruption to homeostasis, our blood pressure is increasing, that's going to trigger those receptors in cardiac muscle, which are specialized endocrine cells that release natriuretic peptides. Those will affect the kidneys and the blood vessels, and that will increase the amount of sodium and water released by the kidneys into urine and suppress our thirst response. And over time, that will lead to a decrease in blood pressure and blood volume. And the opposite is that if homeostasis is disturbed by decreasing blood pressure, then we're going to see that's detected by specialized cells in the kidney, again, specialized endocrine cells, and they will release erythropoietin and renin right here. And then you can see that's going to activate both the production of red blood cells, which will increase blood volume, but also activate the renin angiotensin aldosterone system, which will stimulate thirst and hold on to water by the kidneys, which should over time increase blood pressure and blood volume. So it's a great example of sort of the complexity and some of the ways that these hormones can interact. Okay, so let's talk about how the endocrine system plays an essential role in normal growth. And that normal growth is going to require a lot of endocrine organs. And you can see in this first bullet, we're going to need growth hormone, thyroid hormones, insulin, parathyroid hormone, calcitriol, and all of the reproductive hormones are going to play a role in normal growth. And any change in the concentration of those hormones in the extracellular fluid that are not normal can have significant impacts on that normal growth. Now, something else interesting to note is that the role of hormones can change over time. But let's just take a moment. In your book, there is a great picture, looks like this, and this is going to show you how some of these hormones interact in order to promote normal growth. So you can see we need insulin because we need glucose in our cells in order to provide the energy for growth. We're going to need parathyroid hormone and calcitriol in order to deposit calcium salts in the bone to increase bone length and diameter. We'll need thyroid hormones because those are going to be required for normal nervous system development. And in fact, low levels of thyroid hormones can actually lead to mental retardation as a result of a loss of normal nervous system development. So, an essential hormone for growth. And then the reproductive hormones are going to be really important because the different androgens and estrogens have different effects on different cells, which are going to lead to sort of the classic sex-related differences as a result. So coming back here, just take note that growth hormone plays a particularly important role in cell growth and protein synthesis in children, but in adults, it's not playing that role because we don't need to, the cell growth as much since we have, in theory, already reached our maximum growth, but we still use growth hormone to help maintain blood glucose levels and also our lipid reserves. So your body is kind of getting a twofer out of these hormones by just shifting what we use them for over time. Okay, that brings us to the stress response. And I always think this is a great one to have relatively early on in the semester because chances are we're all going to experience some stress at least a few times over the course of the semester. And so maybe it'll help you to tamp down on the anxiety of that stress response if you better understand the stress response itself. So keep in mind that a stress response is it will happen a stress response will occur due to any physical or emotional condition that threatens homeostasis. So anything that threatens or disrupts homeostasis will lead to a stress response, including like being too cold causes a stress response. Having your blood sugar levels get too high or too low, that causes a stress response as well. So any disruption of homeostasis can lead to the general adaptation syndrome, which is the fancy word, GAS, for the stress response. And it consists of 3 phases: the alarm phase, the resistance phase, and the exhaustion phase. In the alarm phase, we are going to see predominantly this sort of fight or flight response. So we're going to have sympathetic stimulation from the brain, from the hypothalamus, down to the adrenal medulla that will release epinephrine and norepinephrine. The impacts of epinephrine, which is the dominant hormone in this alarm phase, is going to lead to things like increased mental alertness, increased energy use by your cells. We'll see changes in circulation. For example, if we need to fight or flight, we're going to want increased blood flow to our muscles. We're going to reduce blood flow to the digestive system since, digesting our lunch in that moment isn't so important. We're going to see an increase in our heart rate and respiratory rate to deliver oxygen and sugar out around the body where we need it. So that's going to be our alarm phase. Then we have our resistance phase. So this is if that stress goes on for more than a few hours, then we'll enter this second resistance phase. And here we're going to see that glucocorticoids are going to be the dominant hormone. And so we'll still see epinephrine and a little bit of growth hormone and a little bit of thyroid hormone involved, but the energy demands of the resistance phase are going to remain high compared to normal as a result of all of those hormones. And our nervous tissue in particular will have a very high demand. It has very high metabolic rate. And at this point, we may have used up most of our glycogen reserves during the alarm phase. And so what we're going to see during the resistance phase is a mobilization of the remaining energy reserves. So think your fat tissue and also some amino acids from skeletal muscle can be utilized to produce ATP as well. We're going to want to conserve glucose. So our peripheral tissues are going to break down lipids instead of carbohydrates to obtain energy. And hopefully we're going to increase our blood glucose levels through the activation of the liver. And we are going to conserve salt and water so that we can stay hydrated. And if this goes on for more than a few weeks, then we will enter the exhaustion phase. And at that point, we just simply can't sustain the requirements of the resistance phase anymore, unless some kind of corrective actions are taken place. And so it is entirely possible to get really sick. Your body systems are not operating normally, and so you may have reduced inflammation, which leaves you vulnerable to infection. It could trigger potentially a heart attack if your heart's been working too hard as a result. So some of the factors that can trigger the exhaustion phase are going to include the exhaustion of your lipid reserves. So once you don't have any fat or amino acids to break down anymore, that's going to be problematic. Like I said, you may have infections that develop as a result of suppression of inflammation from the glucocorticoids from the adrenal glands. You may have cardiovascular damage resulting from the excess ADH and aldosterone levels in your blood. And your adrenal cortex may just simply not be able to produce the glucocorticoids because there's not enough blood glucose in supply available for that. And as a result, you may also be struggling to maintain adequate fluid and electrolyte balance. So I think one of the things that's important to take from that is how essential it is to try to not stay in this resistance phase for too long so that you don't enter the exhaustion phase, right? So when you enter the alarm phase due to some kind of physical or emotional condition that threatens your homeostasis, the key is like, what can you do to tamp that down so that you don't shift into that resistance phase or don't stay too long in that resistance phase? And also to be aware that a lot of the things that you're feeling when you're stressed are directly related to that release of epinephrine and norepinephrine. So they're totally normal. So, like when you're about to take a test and you don't feel like you've studied enough, that's going to trigger the alarm phase and a release of epinephrine, which is going to cause you to sweat. It's going to increase your heart rate. It's going to increase your energy use, but it's also, all of which can make you feel flustered, right? But it's also going to increase your mental awareness and alertness, which means you're going to think better. So being a little bit nervous when you take a test is actually beneficial to your performance on that test. The key is you don't want to sort of get so ramped up that you're already heading into the resistance phase, which is not going to be so effective for performance on that test. So thinking about that might help you control it a little bit more. Okay. So that brings us to some of the other disorders of the endocrine system, basically, which all come down to one of two things. Either you've got an overproduction of hormones or an underproduction of hormones. That's kind of simplifying it a little bit, but ultimately, that's pretty much what it comes down to. So hypo or hyper secretion of hormones. Now, what's not captured in that description is that if the problem is the receptors are not sensitive, you might have a normal amount of hormones available, but they're not being, your cells are not responding to them. So it's the same effect as if you had a hypoproduction of hormones. So just be aware of that. The three common causes of hormone hyposecretion are going to be metabolic factors, which result from a deficiency in any kind of key substance that you need to synthesize the hormone. So there's something missing in your diet that's preventing you from making that hormone that you need. Physical damage is another thing. So anything that interrupts the normal circulatory supply to endocrine cells or that damages the endocrine cells themselves would lead to a reduction in hormone production or response. And then, of course, there's congenital disorders, which is any time that, basically due to your genetics that you might see that the gland that produces a hormone is too small. The gland makes the enzymes, but the enzymes are abnormal. They don't function properly. Or the receptors that trigger secretion are either not present or not sensitive. Or the gland cells lack the receptors, as I mentioned earlier, for actually having that hormone bind and inducing a response. So all of those are examples that would lead to hyposecretion, too little hormone, leading to issues. So In your book, there is a big chart of endocrine disorders. And so let's just talk about a couple of them. So, growth hormone is an interesting one. If you have too little growth hormone coming from the pituitary, then you're going to see delayed growth, abnormal fat distribution, and particularly low blood glucose after eating. On the other hand, if you have too much growth hormone, you may have gigantism or acromegaly. And so basically, excessive growth is going to be the typical symptom. If you don't have enough antidiuretic hormone, that leads to diabetes insipidus, which is different than what you might normally think of as diet, like the diabetes mellitus that we learned about in class. What you're going to see with a low concentration of ADH is dehydration and increased thirst. And then if you have too much ADH, we actually see people increasing body weight as a result of hanging on to higher levels of water. You can, of course, have hypothyroidism or hyperthyroidism. So if you have too little thyroxine or T3 and T4, then you're going to see very low metabolic rate. If you have too much, you're going to see a high metabolic rate. And you may see Graves' disease as well is associated with increased activity of the thyroid. Of course, if you have low levels of insulin, that would be diabetes mellitus or type 1 diabetes that we talked about in class. If you have too much insulin production, it can lead to very low blood glucose levels, and in some cases it can actually result in a coma. So that's pretty significant. If you have too little glucocorticoid production, that leads to Addison's disease. These individuals really struggle to tolerate stress. They have a hard time mobilizing their energy reserves and keeping normal glucose concentrations in the blood. And I can't say that word. Going the other way, if you have too much glucocorticoid, so hyperglucocorticoid production, that can lead to Cushing's disease, where you have an excessive breakdown of tissues and lipids, and you're going to see difficulty in glucose metabolism. So you may have high levels of glucose in your blood supply. And then just some other interesting ones here. If you, for example, have too much of any of the reproductive hormones, it can lead to precocious puberty, which is like premature sexual maturation. So you enter puberty at a very young age. And of course, going the other way, if you have too little reproductive hormones, it can lead to infertility and a lack of secondary sex characteristics. And I think that's an accidental slide that I have there. All right, and I think that wraps everything up for chapter 16. And hopefully you find this a bit helpful.